hope everyone's doing well this morning. Do feel free to use the chat and do use Q&A. Keep an eye on both. And I'm doing double duty today because I'm sharing the session, but I'm also going to be leading the open forum at 12 o'clock. So I'm going to hand over and welcome Catherine Baker, who's gone a bit fuzzy, but I'm sure she'll come back normally in a minute. Catherine, over to you.
Okay, thank you, Richard. Okay, so I'm going to share my screen. I'm just going to say that at some point I'm going to play a 3-minute clip of an 11-minute film, which I can share the link to that 11-minute film in the chat, maybe at the end. It's on Vimeo. But for now, Richard's kind of going to play just a short clip of it so you get a kind of taste of what I'm actually talking about. So I'm just going to share my screen. So Richard, I can't see you now, as I kind of explained in our rehearsal. So I'm just going to start my timer.
That's fine. We can see it fine. And,
right.
Yeah.
Okay. So yes, hello everybody joining this session. My name's Dr. Catherine Baker. I'm an associate professor of interdisciplinary practice, which is quite a mouthful as a job title. Fundamentally, it kind of means I'm an artist researcher, and I ask questions that are often outside of my own area of interest. So this is my paper. Advancement in modern medicine and innovative diagnostic technologies suggest that we're all likely to experience illness or disease at some point in our lives or through the lives of those we care about. Whether that experience becomes life-altering will likely depend on the nature of the illness itself and how it is encountered, and coupled with the disruption it brings about both physically and or mentally. The impact it has on the way we think about who we are in the world and what that world becomes for us as a result is an individual experience, albeit one that frequently parallels the experience of others. Reflecting on the title of this symposium and the broader definition of borrowing time contextualized through ill health, this talk will introduce art with its potential to draw on creative strategies such as metaphor and health, which is frequently ordered by science and objectivity. Through identified artworks and my own artwork, this talk attempts to articulate what it means to grasp such experience amidst and into practice through art made with participants as co-producers, rather than art made about patients. The makers of the works herein occupy a complex status, becoming multiple things to many people. In the journey towards final outcomes, they act as observers, participants, producers, collaborators, voices, and additionally, and very importantly, they often become friends. Importantly, in these works, the participants align with the artists, becoming relational stakeholders whose voice has agency. In many ways, central to this essay is the highly critiqued Cartesian model of medicine that is based on a mechanistic separation of mind and body. The mind-body problem, as it has come to be known, is presented in the context of two artworks that utilise film as the chosen medium to explore themes including waiting as a factor of illness and the temporal disruption of disease and death in dying. The impact of Descartes' reductionist method is frequently attributed by many from both within the field of philosophy and medicine alike as giving rise to the problematic mechanistic mind and body problem in the condition of disease and or illness. The logic that Descartes so admired of physics and mathematics, when employed in medicine, envisages illness as organised, yet understanding the impact of disease is seldom ordered. S.K. Tombs asserts that the Cartesian paradigm of embodiment lacks completion, and that the resulting disarray is formed from a failure to consider the whole person. In a very explicit way, it omits the person to whom the body belongs, the person whose body it is. The conceptualization of the biological body in medicine as machine-like is amplified through Descartes' comments on the divisibility of the body into its constituent parts, while the mind remains utterly indivisible. Nonetheless, the simplicity of divisible order versus the often idiopathic character of illness and disease coalesce in troublesome ways for those whose lives encounter the impact of illness, either directly or indirectly. For us, the body is much more than an instrument or a means. It is our expression in the world, the visible form of our intentions. The body responds to the environment in an ongoing dialogue, and everything depends on the body's ability to perform, predict, and react appropriately to stimuli. Thus, the body is the core of our existence and the basis for any interaction in the world. All our actions and goals have to be rethought in light of the new role accorded to the body in illness, or more accurately put by Javi Carrel, a new recognition of the role that it was playing all along. Ponti's view of the body as both object and subject, the ambiguity of the body as he calls it, we can see an important dimension of bodily experience exposed in illness. This is the difference between the biological body and the lived body. The biological body being the physical or material body, the body as object, and the lived body as the first-person experience of the biological body. Normally, in the smooth everyday experience of a healthy body, the two bodies, therefore, are aligned. There is an agreement between the objective state of the biological body and the subjective experience of it. In other words, the healthy body is transparent and taken for granted. We do not stop to consider any of its functions and processes so long as everything is going smoothly. These things are part of the bodily background that enable us to do more interesting things. While digestion and fluid and balance and muscular performance are going well, we do not experience them consciously. They silently and invisibly enable us to go about our everyday activities without a single thought. It's only when something goes wrong with the body that we begin to notice it. The disrupted harmony draws attention to the malfunctioning body part, and as a result, it can become the focus of our attention. The artworks presented herein attempt to explicate the profound sense of loss experienced by the alienated self in illness, or perhaps what Ponti referred to as the ambiguity of the body. In Stephen Eastwood's essay, The Interval and the Instant, inscribing death and dying, the complex relations between ethics and aesthetics in film are explored. I'm going to jump forward here, actually, because my slides are not in the best order. Far removed from the fiction of cinema and notions of a good death, whatever that might be, Eastwood's work reveals dying as a lived experience of the deteriorating body. Framed in the context of palliative care and end of life, the multi-screen installation, The Interval and the Instant, launched at Fabrica with a sister artwork entitled Island. The works raise questions surrounding the absence in Western society of accurate depictions of death and dying, much like illness, dying is omnipresent. Eastwood states that somehow the unacceptable vision of dying has resulted in minimal filmmaking approaches that respond to the shared potentiality that exists between the filmmaker and the dying person. He points out that as a consequence, there is very little filmmaking done with the consent and collaboration of the dying person, and there are few moving images of the end of life. In the same way that modern medicine has contributed to an increased awareness of illness as an everyday presence, death persists as the one true constant, yet remains unwillingly acknowledged. As presented, similarly, Eastwood's work provides a profound insight into the private world of disease and illness, and one that I suspect challenges audiences, although I suspect that was not unanticipated. Whilst Toombs and Carell advocate a phenomenological consideration of the person whose body it is in illness, Eastwood likewise promotes the voice and agency of the patient. His approach involves them as both subject and co-producer. This could be considered in opposition to those who might seek to encourage seclusion at such times, shielding the wider connected community from the harsh reality of death in terminal illness. Eastwood points out that the well-meaning situation of palliative care in terminal illness may occlude the validity of the dying person's need to speak and participate in the creation of an image of their dying. I'm just going to skip back to some of my own slides. So while terminal illness, as presented in Eastwood's work, brings the temporality of death to the fore, I'm struck by the parallels that exist between his role as filmmaker and that of the clinical ethicist. In communicating disease that is incompatible with life to an extended community that includes family members, physicians and audiences alike, it seems like an important meeting point reveals itself amidst the possibility of confusion that lurks below the surface. Through my own work in both clinical and non-clinical settings, I've witnessed and shared the intimate experience of being toward death and the ensuing existential trauma that loops endlessly for the individual. Patients with life-limiting conditions are often invited to take part in surveys that attempt to measure their well-being as a process of data collection that has nothing to do with the clinical outcome. Overlooked in such studies is the experience of waiting in illness and the condition under which that waiting takes place. If we scrutinise waiting as experienced, it varies considerably in response to who waits and with what illness, disease or sickness. For my film Waiting, which shows patients and those they share their lives with as they wait underwater on a single breath, my research revealed somewhat expected commonalities that align with the mind-body problem whereby the patients describe themselves as data, as incessantly measured, encountered as their condition and not for who they are. The simple act of holding one's breath provided a powerful metaphor for the participants who co-produced Waiting with me. Despite what might be considered a move towards a persuasive narrative, the inclusion of water as both a life-sustaining but threatening material attempted to intensify the involuntary nature of breathing for the audience, who were invited to hold their breath with the people that they saw on screen. The accompanying sound, composed from recordings of magnetic resonance imaging sequences, echoes the process towards the search for a verdict, while scenes of empty, impersonal clinical spaces focus and tell again the repetitive narrative bleep of medical settings and the clinical diagnosis. In Waiting, the people we see on screen hold on to breath, each other, and life as it slips away with surprising speed or is wished away in the hope that certain conditions will reveal their full impact more quickly. The unknowns of illness wreak havoc in the temporal experience of being, and time can appear to run fast, yet pass slowly when waiting for results or the right time to tell others. Richard, could you play the film now? Thank you. Hi, Richard. You could stop it there. It's just the credits. So I'm going to go back to sharing my screen. So when seen through the lens of the artworks herein, and in the broader context of contemporary medicine, the mechanistic orderly separation of mind and body as presented through Descartes' philosophical meditations is clearly inadequate in reflecting the complexity of experience. However, this talk hopes to have articulated that within the problematic inferences of critical illness, whereby people, both patient and physician, find themselves not on the same page, a broader consideration of moral distress in waiting for illness to fully reveal itself is necessary, and maybe repeatedly bearing witness to trauma goes some way towards explaining why the mind-body dilemma has endured in the context of the disrupted body and those who seek to treat it and or comfort. Dr. Alicia Burghardt, a paediatric anesthesiologist and bioethicist, which I have to say is not easy to say, in conversation with Professor Ian Sabaro earlier this year, described her position, saying, "It is traumatic to be a clinician. We are sitting in people's pain and suffering." What is clear is that adapting to or conceptualizing uncertainty seems significantly more critical than searching for the certainty that Descartes pursued. The patterns that emerge in the repeat in the context of disease expose the chaos of temporality and illness, revealing that which was perhaps all along, the difficult problem of our awareness of time. When data and measurement fall flat and the limitations of language are exacerbated, artistic strategies employing creative metaphors that attempt to enhance our understanding of the intangible and the invisible have the capacity to bring about the creation of a meaningful dialogue attending to the mind-body issue for both clinician, individual, families, and a future audience. I just wanted to finish with this. So one of the people who joined in as a co-producer in the film Waiting that I made was a lady called Suzanne, who sadly didn't survive long enough to see the final iteration of it. However, an earlier kind of version of it, before the soundscape was fully revealed, was displayed that she was able to go to. So the patients who there suffered with things like, so Suzanne had stage 4 cancer. There were people with autoimmune disorders, connective tissue disorders, diabetes, type 1 diabetes, scoliosis, and so on. The range of illnesses was very wide, but often people who were waiting, but in very different ways. And why I think one of the reasons why I captured this slide, which you probably recognise is from Facebook, was that actually you can often become people's friends in the process of working with them towards producing artwork that is about raising awareness. And so for me, it is a very privileged position that you can find yourself occupying. Thank you. There are a few other references that I've realised are probably not in here. If anyone's interested, I'll put my email address and I'm really happy to pass on some of the references that I've mentioned throughout this talk.
Thank you very much, Catherine. One of the things we can do, because a number of people, I think, are quite interested in seeing the whole film.
Yeah.
By all means, share the link in the chat, but we could also, if you sent us the link, and a couple of images, we could add it at lunchtime. We can add it to the expo so people can access the whole film there. Yeah. If you'd like to do that.
Yeah, I'd love to do that. That would be great. I'll have to look up the Vimeo number.
That's quite all right.
Whilst Sophie tries to navigate the virtual world of hopping, I can look it up to make sure I get exactly the right one. I'll put it in the chat, and then maybe that would mean you post it in the Q&A.
Yeah, sure. Okay.
Great.
We've got some, I just wanted to say hello to Sophie, Strand and Alicia Grace, who are going to be joining us on the screen at 12 o'clock. Just to say, yes, we are here, and yes, we'll guide you into getting you on the screen. So don't fear about that. We have some very good, nice comments coming in the chat, and I wanted to pick up one that from Aubrey here, who says, I know little about moral distress, but understand it is a concept that is increasingly being discussed and studied. Does this apply to those who interact or care for the dying, as well as the dying individuals themselves?
I have to say, I think it's a term that I've come across much more over the period of 2020-21, and it is a phrase that I've encountered with more so with ethicists, so medical ethicists. So they have a slightly different system in the States, whereby what they would probably call physicians, or we would call clinicians or consultants, will engage and ask an ethicist to join them on their rounds. And there's a far greater investment in this in terms of addressing some of the problems that have come around language, what a clinician would term as treatable, which actually means in certain circumstances that it is not curable, and that there is a bad mismatch between what the kind of clinical language represents and what it actually means to the patient. So that's one of the bits I said about when they think they're on the same page, but in actual fact you can find that they're not. More of my research has been orientated towards the living, but those who are living with long-term chronic illness. So in the context of dying, yes, I think it is still a term that is kind of applies more in that context. The place that it's come about for me is actually a sense of inquiry. I was kind of quite curious about this sort of mind-body problem, and about the writings about the relationship between kind of illness when we consider it in a phenomenological sense. And some things that emerged in my own research and practice, which some was being in a theatre observing some surgeries, was about whether we really actually wanted the person who makes very critical decisions about our future health and life. So, for example, one of the surgeries I watched was a scoliosis spinal fusion, full spine. And there were 16 people in the theatre that day, excluding me, and everybody hanging on every word from the surgeon, who, with a moment, a split second of distraction, could cause a young teenage girl to become a paraplegic. And it made me kind of rethink a lot of the things that I'd read around the relationship between sort of phenomenology and illness, and whether we actually do really want the person who makes those critical decisions at that point to be that engaged subjectively in the life of the patient. My experience, and I haven't completely made up my mind about it yet, but so I have to say it's something that I've been writing about and grappling and reading, is whether that there is a reason why Cartesian dualism and this mind-body problem has endured, because perhaps we need those people to have that distance and that objectivity, and that actually trying to remove that might be problematic when we need other people, the people that we go to say, fix me, when we need them to make those very critical decisions. I don't know if that's sort of gone off in tangent slightly, but yes.
Well, I think it's probably going to prove to be a fairly perfect segue into the next segment, because my own experience of being in a surgical environment, which is fairly extensive, there's the absolute cliche about the difference between physicians and surgeons, and you're absolutely right that surgeons are the ones who tend to be more removed. And so the cliche would say they have to be like that because they are not operating on a person, they're operating on a mechanism.
Yes.
And so the whole body's covered up, and they're only seeing the mechanism that they're trying to fix. They're not addressing the human. But I had to turn that completely, and I'm probably playing with dangerous fire in bringing this into a gendered discussion, but I have to throw all of that out when from my last surgical encounter, where not only the surgeon but her entire team were women.
Right.
And the way that I was addressed, even talked to, involved in the conversation, was entirely different. Now, it had nothing to do with gender. So I don't really want to make this a gendered conversation, but I think it was my first experience of a surgeon who was clearly addressing me, the mind, as well as the body. And even in one instance had diagnosed a post-surgical problem before the data confirmed it. And so that whole question you mentioned about patients being seen as data is hardly surprising. Yes. In the kind of environments that you're talking about, where, as you say, people are measured to death.
Yeah.
So you're measured every 4 hours, or if you're poorly, you're measured every 30 seconds, or and actually very often, the teams coming around will look at the data before they look at the person.
Yeah, absolutely. And actually, there are some ways in which we sort of understand that continuous measurement. And then there are other illnesses, say like something like scoliosis, where young people at probably the most critical psychological development stage of their lives have this very slow measurement. Yeah. So they, depending on the severity of their spinal curve, will have to go for very deep, harmful standing X-rays, potentially every 3 months, at least yearly, possibly for 5 to 6 years, because this illness doesn't reveal what it's going to do fully to the individual and the way that their future life is going to play out. And so there's these sort of different kinds of measurement that are quite complex. I mean, one thing I'd add in that, what you were just talking about, Richard, in your experience as a surgeon, when I was observed this sort of 4-hour spinal surgery, the patient was a 13-year-old girl. My daughter at the time, I think, was 15. The patient was brought in, and the nature of the surgeries is they prep the patient, and the only bit of her that was visible was her spine. That's been doused in iodine, and then it's coated with like a cling film-like material. And so immediately it's not flesh, like this distancing occurs where you're not able to recognize the body in that way. It doesn't bleed because it's cauterized. So yes, there is an element of blood about it, but in actual fact, this whole kind of distance away from the body and the sense that there is a young girl lying under all of this blue paper just sort of disappears. It's a very strange experience. 4 hours later, when the surgery finished, all of a sudden I was confronted with them taking everything off, and they turned this young girl over, and I saw a 13-year-old naked, prepubescent kind of body laying there, and it was like someone had hit me with a bat. It was such a strange experience. It's something that I'm kind of writing about at the moment, because I feel it's something that I have to, in order to be able to sort of get to grips with what the experience really was. So that kind of clinical context is a really, really strange place for patients who do wait slowly. So, are not in a life-limiting situation. They're in a a situation where their life is altered by their illness, and the constant way in which they are kind of measured and engaged with clinical settings and the people who occupy them.
I'm going to move us into the open forum, but thank you very much, Catherine, and particularly for sharing the artwork, which looks really quite stunning, and there's lots of things we could say about that, but as always, there is time. So I just want to introduce this next session. I have invited 2 guests to join me, but this is an open forum. So if at any point you want to come on the screen to ask a question or join the conversation rather than using the chat, all you need to do is click on that button that says join with video and audio. So if I can invite Sophie and Alicia to do that, just to prove the point, that will bring you onto the screen, but it is open. So if anybody else would like to bring themselves on at any point, that's absolutely fine. So let's see if we can find Sophie and Alicia. Yeah, there's Alicia. Okay. Sophie, are you still there? Sophie, you are still there. So can you, do you have the button that allows you to join with video and audio? How do I do this? Okay, there should be a blue button there at sort of the top right quarter of your black screen. It should say join with audio and video. If it's your first visit to hop in, it's a little challenging too. As we were talking earlier, it's a bit challenging to navigate. Hopefully you'll be with us soon. If you can't get yourself up there on the stage, as it were, I hope perhaps you can join in with using the chat. So Alicia, I'll start by just inviting you to, actually Tom, sorry Tom, come back. Tom is quite right. It might say ask to share audio and video, and if you click on that, I can let you in. Alicia, I just wondered if you had any immediate response to what we've just heard. You had put some comments in the chat too, which were interesting and very valid, but I just wondered if you had a particular response to what you've just heard.
Catherine mentioned something about medical ethics or ethicists, and I've always kind of had this little fantasy that medical ethicists, particularly those dealing with genetic conditions, might have training in disability arts and culture around illness and sickness, and just to kind of like widen horizons and ideas about what a life with a chronic condition or genetic condition can be, like the possibilities aside from the clinical limitations. So that kind of sprang to mind when you were talking about the ethics side of things. I don't know if that's something that maybe happened somewhere. Have you ever come across that, Catherine?
Well, the only clinical ethicists that I've actually come across have been based in America. So I think it's, the discourse around ethics for me, I think is growing and it's becoming increasingly more important. I think it's something from an artistic point of view that's been very inadequate. I think there's lots of really difficult things around ethics in relation to artistic practice. The process, and including, I mentioned to Richard earlier, I'm going through an NHS ethics approval for a scoliosis project that I'm running at the moment. And actually, it's not like the meaningful ethics that I might write about in relation to practice and working with patients with long-term kind of conditions. It's so much about insurance and indemnity and governance, sponsorship, which I think is really unfortunate. To go back to the ethicists that I have encountered, most of them originally came via a philosophy route. So they've done sometimes 2 PhDs So they've got to a point where they've done a PhD in philosophy, and then the nature of their kind of careers as they've developed. I mean, Alicia Berghardt, who I mentioned, she is a paediatric physician, but she initially trained in ethics, and so her background was in philosophy and looking at ethics, and then she's applied that in the context of her role.
So, Sophie, you obviously know plenty about the American context, and you know plenty about the medical context. I just wondered if you wanted to come in.
Oh, it's interesting. I actually studied briefly medical ethics in college, and was a little shocked at how underdeveloped it was as a philosophical or ethical practice. I don't think it has infiltrated any of my medical experiences personally. And I also think that a philosophy degree is like the least, is poorly suited to what medical ethics might actually be. I would perhaps want someone making those decisions about what medical ethics is to have spent time with dying children or terminally ill people for years. I would want a kind of praxis that I don't think you get with a philosophy PhD. Yeah, I don't think that there is any ethical element to medicine in America right now, personally. You're always, I mean, Catherine, I was very moved by what you were talking about with the girl experiencing the surgery on her spine earlier, because in my life, that's what it's been. I've always been an object. And I feel as if I've almost died because I've been treated as an object and not as a human being who can interject and offer perspective. So I was deeply moved by your observation. Thank you.
I mean, it's part of the reasons why the film actually didn't have any speaking in it. The sounds were just diagnostic in terms of they were recordings made of the impact of seeing under the skin and what the implications mean for the individual. But all of the patients, whatever illness or disease they were living with, or the diagnosis that they've had, all describe this kind of feeling of just being measured and being understood only as their illness, and therefore kind of feeling like they'd lost their voice, they'd lost that capacity to assert themselves, that this alienation had kind of happened. So yeah, completely, that sort of rings absolutely true, Sophie, with my experience.
I wanted to bring Alicia back in because there was some discussion in the chat, Catherine, during your talk about the patient voice. And the patient isn't even the right word to use, but in the medical context, the human voice, and how certain categories of patient or person are not listened to because there's an expectation that they are perhaps unable to contribute their own thought. And I mentioned that, you know, the in inverted commas, the old and the near death as being an example of that. Alicia corrected me quite correctly, so I just wanted to allow you to correct me publicly.
I've been ill all of my life. I was born with a tumor, a rare childhood cancer, and so I've always been around other people who are chronically ill and disabled. I've worked a lot in the disability arts, the UK disability arts culture and disability rights, and I have met so many disabled people who, I have to say, this is probably people of a certain generation, which may not be true to now, but were almost kept alive to be experimented on because of how the worth of their life was seen. And so that is a thing that is not reserved for people who are older or terminally ill. And my own experience of that was that I was very sick as a baby and into a toddler, and my mother took me to the GP repeatedly and was sent away being told that there was nothing wrong with me and that she was a a worrying mother. She was an over-worried mother. And the consequence of that is that the stage of my tumour was so much greater that I lost the organ. Whereas if I had had the earlier diagnosis, I would have kept that organ, and also the tumour then metastasised to my heart and lungs. So I also have, significantly life-changing consequences to having not major surgery twice before the age of 5 and losing, one kidney and a bit of my heart and a bit of my lung. So, it is. And I also know that there are certain people, such as women of colour, even in this country, who report being treated very differently in maternity services, for example. So it's the notion of not being heard or listened to or trusted is greater than the reserve of the terminally ill or older people. Which is not to deny that.
You might be interested. There was over lockdown, there was a series of I think they were entitled "Conversations Across Medical Humanities." It was the University of Kent, I think, who were the main organisers, and they're actually on to round 2. They can be found on Spotify. They've got sort of, they podcasted all of the live lectures. But actually, specifically, there is one in the first round. I think it's number 6. And there is a guy who is a medical ethicist based at Stanford who talks about exactly that situation, whereby, and Sophie might be able to kind of correct me on that. I'm not sure of quite the terms. I think the equivalent of what we would call a consultant and a registrar, the relationship that's in the States. So they had a patient who was incurable, and the medical ethicist was brought there, but he was kind of really interested in the linguistics of when people do believe that they're having the same conversation, but that they understand that conversation very differently. And the registrar had wanted to run a number of tests on the patient that would have no impact on the clinical outcome, and actually could have been quite distressing to that patient who was in an end-of-life situation, not immediate, but sort of into the nearer future. And the consultant had kind of said, yes, you should do that because it would be great to get that data. And you can see a sort of slight rationale in that. Well, if we learn more about this illness or this disease, that we might be able to help future people. But this was not in that context at all. It was about the education of the registrar, or what that term, maybe junior doctor, would be. I think in the UK we have there are debates that are happening around how we train medical students, and they're looking to the wider humanities. I think that's going to be interesting to see what happens there, and about the willingness of those medical students and the kinds of people that are recruited to medical degrees, which, that's another whole other agenda for me. But yes, absolutely, those scenarios I think are rife, and it is part of the training process, which is very worrying.
I have to say, on the flip side, I have seen a generational shift, like in my own experience of particularly registrars, and especially oncologists. Oncologists seem to have this very, I don't know, a different kind of intelligence, a different kind of willingness to engage, with their patients. I can't, I wouldn't want to criticize my oncology team, who are just absolutely fantastic. And I think there's something about, particularly if you are a patient that is able to articulate and in a very particular way and take possession of your story. And this is something that came to mind when I saw Sophie speak a few weeks ago, which was there's something about people with long-term conditions who we become very good at telling our stories because we have lots of practice, because we have to keep telling them. And if you can take possession of that, particularly in a kind of literary way, in the way that Sophie does and I have done, you gain power. And I'm sort of always looking for ways to Trojan horse the arts, like a defense of arts education, like wherever it can be, because the power of that is, is the difference between able to stand up for yourself. Like I'm always saying, I'm good at filling in forms because I'm a literary person and I know how to tell the story. And I don't know, maybe Sophie, you could come in on this, your ideas about talking about the story hanging between the ripe and the rot.
Thank you for sharing, Alicia. I really identify with the experimentation element, especially because my condition is rare and incurable. So I'm a test rat. I'd love to just test every new experimental medicine they have on me. And it took a very short time for me to realize that that was not going to be in my best interest. But I was going to have to actively set those boundaries that I didn't want these treatments again and again. I think I actually, my ideas about storytelling, narrative, and illness are constantly shifting. And I guess I would turn this back to Richard and to you, which is sometimes I worry that I do have too much of a story. And that I don't want the story of my doctor, and I don't want my story. And how do you dwell between shells outside of your story? How do you sometimes take a break from what you think is supposed to happen in terms of your health and open up space for the unexpected? Because sometimes I think that I'm living a story that isn't as generous as it could be. So how do you oscillate between certainty, self-defense, getting what you need, fostering that healthy autonomy that helps you navigate the complexities of the medical system, and also opening up space for not knowing? So I would give that question to you, Richard, and to you, Alicia.
Well, I will respond to that. When I was diagnosed with Crohn's disease when I was 20, and I probably had been active in me for a lot longer than that, I was, despite my own feeling of being gender neutral, I was still a young man. And therefore, my response to it was, first of all, to ignore it, to pretend this was not really happening. But it wasn't long thereafter that I was put in front of I have to say, a rather aged surgeon who, without really having any form of conversation with me, started to draw the bits he was going to cut out. And that would basically have been pretty much my bowel. So that would have been it, that would have changed my life very significantly. And I knew even then that I was not going to do that. And at that point, the notion of refusing a consultant was kind of unthought of, even in the we're talking about the late 70s, mid 70s. It was kind of unheard of to challenge somebody in that way. And somewhat later, this came up again, sort of probably 20 years later, and again, I refused to have the radical surgery that was being pushed on me. And my physician at the time, who was a very dear but very loud Yorkshireman who laughed very loudly all the time, after that, forever thereafter, would introduce me to people as, here's Richard, he's a music professor, but he knows about his disease, and so that was something extraordinary. I should only know about music, perhaps. And he turned down the surgeons. Ha, 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 isn't that great? So the whole dynamic of where I am in all of that has been really interesting. And I feel that I knew from day one that I was not going to be defined as a person with a chronic illness. And what I mean by that is I was not going to let it dominate every aspect of my life. I knew it was there. I did some foolish things. One of those foolish things was moving. I went to California to do my postgraduate degree, and had been told ahead of time, don't, whatever you do, go to the US. And I did, in fact, become so ill that it was probably the closest I'd come to total failure and death because I couldn't get the treatment that I needed. So my and I always refer to these times of flaring disease as a period of waiting. So it's again about waiting in illness. It's about a period where your life literally goes on hold. Everything else shuts down. You just let the process then unfold. And when you've been through it a few times, you know what that unfolding means, and you know that there's an end to that process. That it's not like a degenerative disease. It's a disease that's going to flare and be fixed, and it's going to flare again. And cancer is like that. Cancer is, of course, can be life-limiting, but it's also very much a disease that's in remission or not. And I think you do start to learn to live with those periods of time where, okay, this body is ill and I'm going to let it fix itself or get fixed. And then I come out of it and I can kind of find my consciousness again, if you like. So I think I do suspend consciousness to some degree. Although as I've gotten older, I think I've got better at probably not doing that. But anyway, that's a rather long-winded response to your question, Sophie. I'm going to bring in Tom, who's just appeared on the screen.
Just to follow yours, Richard. I mean, I'm. There's a point I made in the chat, and I'll come to that in a sec. But I'm asthmatic, so it isn't necessarily such a life-threatening condition. But I've been asthmatic since I was as long as I can remember. So as a very young child, I had various asthma attacks where my parents were then trying to figure out the depths of it all. And then I've been medicalized my whole life using inhalers. I also have had my stepfather is asthmatic and has a terrible lung condition as well, where he's had the bottom half of each lung removed. And as a man in his 70s, he's also got a heart condition. So it's this that has developed. And I'm just sort of thinking about the difference of, I don't know, thinking about you going to the States with knowing you had the condition and knowing that it would be more difficult to treat in the States. And I know for myself, being even just asthmatic, just being able to get the inhaler, just having that little fear in the back of my mind, it's probably hindered my life a bit. I don't think I have that side of a personality that goes, actually, sod this, I'm just going to plow on. But I'm maybe a bit more cautious. But it's not really anything other than that, really. But just thought I wanted to share that. But I also wanted to just come to the point that I made in the chat, which was I'm just going to go back to it, and I can't remember exactly where it came from, but it was the issues around sort of the physician or the registrar and the communication with the patient, human being. And my sister trained as a GP, her stepmother, who I talked about, her mother rather, my stepmother, who I talked about in my talk, who passed away 20 years ago. She was a GP and then trained as a homeopath. So her daughter wanted to follow in her footsteps. She trained as a GP, worked as a locum in hospitals around Manchester, and just in the end decided that she couldn't practice the way she wanted to, because for her the practice was about connecting the human to the human, not just seeing the patient as a machine or a component that is wrong. And she ended up leaving the profession. And,
because general practice should be the very place that you can do that.
Yeah.
But it's hard to do.
Yeah.
Alicia, I don't know if you wanted to respond to Sophie's thoughts. I want to come back to Sophie shortly, but I just wondered if you wanted to chip in.
Yeah, I wanted to come back on the idea of what do you do with your story, and how it can dominate life, and perhaps how sometimes you might want to leave it alone or take different perspectives on it. Certainly through the pandemic, my response with that has been to stop writing. Like, I just wasn't able to, like, the consequences of my illness and having to shield and living in inadequate housing as a result of my economic status of being ill, like, was so concentrated that I was not in the mental position to be able to keep telling my story in a literary, artistic sense. I was still having to tell it in a kind of medical, bureaucratic sense. And so, I mean, I've just had to let go of my storytelling, of my writing, and I've just turned to music, and I'm studying music theory because I just need rules. Like, it's all I can cope with is rules. But the other thing that I've started to do, because I don't know if, you know, Richard and Sophie and Tom to some extent also have this, is that people begin to relate to you from that axis of your health. And it's not, you know, it's not always the thing that you want to be focused on. And so I've kind of started to turn it around. I mean, I've always done this to some extent, but I'm doing it now more consciously, which is to talk about what's going on ecologically, environmentally, in terms of my very real situation, but, you know, on a larger global extent. So I tend to turn the conversation around a bit more, particularly to notions of air pollution, because I'm particularly affected with, you know, lung condition. And Tom, I don't know if you're aware of the work of Rosamund Adu, what's her name? Kissy Deborah. She's the mother of Ella Adu Kissy Deborah, who was the 9-year-old girl that died of an asthma attack in 2013. And there was a landmark coroner's ruling that put air pollution on her death certificate. And her mother is now an environmental campaigner. And I heard her recently on the radio say that during the pandemic, when there was not so much air pollution, that no children died of asthma in the UK. So that was between March 2020 and February 2021. So that was just to say, Tom, don't play down asthma. Like, you don't have to play that down in the company of, you know, what you might perceive to be more serious conditions. It's as serious as your life, you know. And I suppose there was also this thing about the notion of cascade, about when vulnerable people have a point of vulnerability, that there's a cascade from that, in that their vulnerabilities increase, and that's something we've seen through the pandemic, but we also see in terms of environmental crisis.
I want to bring Sophie back in, because Sophie, you very much used writing not just as a way of responding to your illness, but actually to let it be part of it, almost to use words and metaphor and poetics to embrace it in some way, to have a conversation with it.
Yeah, I would offer that me writing about my illness and owning it as some kind of visible, legible part of my life is relatively new, and I very much sympathize with Alicia about not wanting it to be how people first see me. So me sharing and creating writing that is very intimately dealing with my illness and grappling with it is a new thing for me, and it's not totally complete or understood by me yet as a mode of expression. I'm not sure where it will go. I do know that it has done something invaluable to me, which is it has shown me that although my experience can be very strange and isolating, it has connected with the experiences of a lot of other people in varying degrees of chronic and terminal illness. And it's that connectivity, you know, I have genetic connective tissue disease, and to be able to use that connective tissue disease to create connective tissue between people. I mean, look, I'm talking to people in England right now, early in the morning. Who would have known that the mycelial webs would weave me into all of these different amazing communities just by virtue of trying to repeatedly name, unname, name, and unname what I'm going through. And I think that's the one constant, is that I'm always trying to create a new metaphor, always trying to defamiliarize myself and my own experience of my body so that perhaps I can see something new. So if I write one piece, it's knowing that it will wash away with the tide like a sand castle the next day, and I'll have to try and reassemble something new. Yeah, but I feel, Alicia, about wanting rules and wanting a stable value system and some kind of theory of how. The one difference, I think, Richard, between me and your illness is I have flares, but I also have degenerative disease. So sometimes when I'm in a flare, I never know if this is it, if this is going to be like, if I'm never going to get that back. So there's always this sense where something goes and I'm not sure if it's gone forever. And you live in that uncertainty. It's a very interesting place to write in.
Yeah, absolutely. And you know, I have the same experience in the sense that every time I go through a surgical episode, I don't know whether the outcome is going to be good or bad. And every time I go into it, it gets more complex because of the damage that's already been done by previous incursions into my body. So that now the surgical process is weighed differently because the equation becomes, now we know that every time we open you up, we have to spend literally 8 hours separating everything out before we can actually see where the problem is. Because once the you know, the gut is one of the most is a living organism. It's actually by many doctors considered to be an organ. It's not just a big lot of tubing. It's an intelligent organ, and it doesn't like being messed with. So the moment that the very first time that someone's gone in there and handled it, it starts to send out little tendrils to kind of say, hang on a minute, something not good is happening here. And so the gut literally starts to grow into itself. Sorry if I'm making this a bit too graphic for people, but that means that now when there's a surgical intervention, they have to deal with all of that before they can actually get to the problem. So every time this happens, the question of the outcome is more uncertain. So in that sense, yeah, I completely agree with you that you don't really know whether you're going to come back to a state of normalcy, as in normal, you can cope with it, or whether actually it's not going to work. And so that uncertainty is possibly one of the most interesting states. I would have described it as scary at one point. Now I describe it as an interesting state because it's a very strange, almost an interstitial kind of space where you don't really quite know where you're going to come out. Sorry, I don't know where all that came from, but yeah, and it's Sophie.
I have a question for you and for Alicia, and also for Tom, whoever wants to respond, which is, how has your experience of illness complicated your idea of porousness and of individuality? I'm thinking, what does it mean, Richard, to have been opened up and to have been worked on? How does that complicate your sense of self? That's something I've been grappling with personally.
I think that's actually a really interesting question that I think for me it comes back to this question of waiting, this question of suspending your life, and actually you do suspend self. That's not to say I'm not an assertive patient, because I'm sure I am, but there is a certain level of individuality and a certain kind of sense of the ego that you have to let go in order for somebody to then be allowed to come in and do that to you. Because if you're kicking and screaming all the way, it's not going to be a symbiotic process. It's going to be a destructive one. So I think I do let go. I think but I know I'm not letting go forever, but I do let go. Yeah, I'm not me when I'm in that position.
I think the pandemic has really shifted that for me. It's almost like made me more conscious of perhaps something that I've always felt to do with the ego, which is just this thing about just the notion of having to let go of things all of the time, let go of aspirations, ambitions, dreams, but not even to that extent, sometimes just day to day, regular activities, like the constant kind of readjustment. And I think you might have used the word yourself, Sophie, reinvention, in the last talk that you did. And it's kind of like, I sometimes think it's quite useful, because some people spend a lot of time trying to find that level of like enlightenment and oneness, and it's almost like they're at my disposal. But there's something, I suppose, at the beginning of the pandemic, there was a lot of talk about how there wasn't going to be enough room in intensive care units, and that doctors would have to make a decision on whose lives to save. And there was a lot of conversation and debate in the disability world here about disabled people thinking that it was probably going to be them that were going to be the people to be, let go of, or not given the bed, because if they were seen to, the medical profession, some people in the medical profession, or at least the media, were saying that that doctors would prioritize ventilators for people who were most likely to survive the best. And so for a lot of us, it was just like, oh, well, like it's a fight, like there's so many fights to have as a disabled person, or as a poor person, or somebody experiencing violence. It's like, but that's the ultimate, like, one that you don't get to have your say in. And so for me, it's kind of changed things. Like, I wanted to go back to something Catherine said earlier about measurement. And this is also something that shifted for me during the pandemic, is I've started measuring myself more and taking possession of those like essential checks. So just something as simple as buying a pulse oximeter and measuring my oxygen and my heartbeat. But the other night I was measuring my heartbeat, and it was like, the pulse oximeter was looking really like unhappy with it. And my partner, who's a musician, he's like putting his head to my chest, like really trying to hone in on like my heartbeat, and with his musical ear, and he's like, I'm really not happy about that. And at that point, and it was like a Friday or Saturday night, we had to make the decision, like, are we going to go to A&E? And the idea of waiting in A&E for like hours with people like vomiting and like having COVID and God knows what else, like A&E Friday, Saturday night in the UK, probably worldwide, not a good place to be. And I just said to him, you know what, I'd just rather die. And it wasn't like, it was just like, I can't cope with that environment right now. It was so cozy. I felt well, apart from this like strange heartbeat, like I felt in possession of what was going on. But I now realize for him, like, how awful that must have been for me just to go, you know what, like, I don't want to ruin this right now. Let's just see what happens. And it turns out, it was okay. I'm fine. I'm still here. So that ego shift, but there's a flip side to that. And this is something that's spoken about in disability theory, which is like hypervisibility and invisibility that sick and disabled people experience. So in some ways, it almost feels like, your ego can become too fueled by the notion of your separateness or your difference. But then that isn't really kind of like backed up with the quality of your life that you might experience. Yeah.
Catherine, you wanted to come in.
It was just partly what Alicia was saying. Thank you for that. It's one of the reasons why, for a lot of the work that I've done, I work with the extended people, not just the patient. We've established we don't really kind of like that word, and I don't think that it's adequate at all. But, in the context of that sort of waiting, which you were also articulating, Richard, that wait doesn't kind of happen alone. The experience of it is very different, but for parents, and my daughter has illness, I won't go into what they are because she'd be furious, if it's, I don't know. But she has a number of quite complicated, lifelong chronic illnesses. So as her mother, I wait in a really different way, you know. And when I have a conversation with her that she just sort of says, I don't feel very well, I'm immediately hyper responsive to that, when it might just mean that she was out partying a bit too much the night before with all of her friends at university. But so there's a kind of, you know, an incredibly different way in which people experience that illness, and that they also wait. They just wait in a very sort of in a removed way from the person who's experiencing it very physically. And I think that's kind of an important part in kind of a lot of the research, is actually that we shouldn't forget about those families. We shouldn't forget about the partners and the people who are always around and do that waiting. You know, most people don't sit in A&E alone. They don't sit in waiting rooms alone.
That is very true. I'd love to pick up on that, but Aubrey has had a question in the Q&A for a while that I want to read in. And she says, I'm wondering about your ideas regarding how to find breath as opposed to holding it during the waiting period in illness. It seems like creating art is one meaningful outlet. And I'm also curious about any recommendations you might have regarding leading thinkers or writers in the space of disability ethics to help scholars and practitioners connect to relevant issues in this space. And Sophie's holding up a book.
I thought Sophie's probably a better reference. Actually, most of the patients that I've worked with fall in that really uncomfortable space of they're not disabled enough. You know,
yes, sure.
Parameters. Yeah. So they live with a lifelong condition. They don't get a great deal of support as a result of that. So they have chronic flare-ups that prevent them from going to work. They pay for their prescriptions, loads of different things, because they don't fit this parameter or this guideline of what it means to be disabled, which in itself presents an enormous number of difficulties, particularly for families with very little disposable income. And that now in the UK, since I think it was May this year, where young people, students in particular, with long-term conditions are now in England, I shouldn't say the UK, in England, as opposed to Scotland and Northern Ireland and Wales, I think it's Northern Ireland, but definitely in Wales and Scotland, don't pay for their prescriptions. So students with no income who have lifelong chronic illness are now in this country kind of being. So I think, I mean, in terms of kind of disability ethics, I think probably Alicia is a better port of call for Aubrey's question. With regards to the one about finding breath as opposed to holding it, I mean, that's quite curious. For the people that I worked with, you know, their narratives were so complex that actually in many ways to make artwork with them about it sometimes seems too cursory, just, you know, a sort of a slightly futile experience in some ways, you know, but in a way they found it a particularly rewarding experience. So for Suzanne, who had very little time left, they decided that they would not operate on her, and there was no one in the UK who would operate on her. And she was dealing with enormous sort of existential kind of angst of kind of driving herself around the twist every day, asking questions for which there were no answers. And then I would say to her, you know, you're not allowed to drive with a lot of treatments and things like that. You know, would you like to come and play around in the pool for a few hours? And she just sort of said to me, you know, that actually just taking her out of herself for a while to go and do these sort of seemingly quite silly things. Because what you see in the film and you see in the talk that I gave are these very distilled, quite pared down images. But in actual fact, the reality of that was a great deal of fun making. You know, we used dry ice to disrupt the surface of it, realise that sets the fire alarms off in swimming pools, and fire brigades turn up, and then they kind of say, what are you doing? There's 26 people sitting around the side of a pool waiting to get in. So in actual fact, kind of, it is a meaningful outlet, but it's a meaningful outlet in the methodological kind of process that isn't necessarily articulated in a very obvious sense.
Yeah.
For Aubrey, she might be really interested in reading some more about Javi Carrel. So Javi Carrel is a philosopher, but who was diagnosed, I'm only going to call it LAM, because I'm not brave enough to try and say out what LAM actually stands for. So she's based at the University of Bristol, and she was diagnosed with an incredibly kind of rare and severe lung disorder. She writes more beautifully than I could about someone who's trying to find a breath.
I'm going to come, thank you for that, Catherine. I'm going to come to Sophie in a moment. But I just wanted to throw one thing in about breathing, which is that one of the things that happens to me, and I'm sure it happens to others, is when you are in intense pain, what I think clinically is called exquisite pain, you can't breathe. Mm. And I think that's actually one of the ways that you can make a quick diagnosis of a degree of pain is that you actually can't breathe properly. But Sophie, let's hear from you and have a look at your book.
Oh, I was just, this is a great book. It's not technically about, disability ethics, but it really is. And it's one of the best books I've read about it. It's called Against Purity, Living Ethically in Compromised Times by Alexis Shotwell, who is a Canadian anthropologist who deals a lot with disability justice. And I really recommend it.
Can you put that in the chat for us at some point? Not now. But...
It's not. I have to be honest. This format is not working for my computer. And
okay.
I can't access
Don't worry.
But yeah, Alexis Shotwell. I can send it to you, Richard.
Yeah,
and you can.
We'll share it. We'll share it in the event chat later, everyone. Yeah.
Yeah. So I have serious lung issues, asthma, and I've had anaphylaxis where you stop breathing many, many times in my life. And it's this moment where your beingness is, just a straw, everything else erases because every single breath stitches you to the present moment. And, Esther Perel was saying that one of the issues with the pandemic is that it's forced normal people who don't deal with illness into a kind of enforced presentism. There's no future, there's no past. You're inside of this constant dilating now that is completely inscrutable. And I think the way to find the breath is actually to surrender to that presentism. And sometimes the only way you can get through those moments of exquisite pain is to just follow that thread of what is available. I oftentimes call it like I feel like I get erased when those moments happen, and you just kind of have to let yourself be erased. There's no art making that can happen in them. You have to just trust that there is some thread of you that's going to guide you through the spiral, through the labyrinth, Theseus-like. The one thing I'd also like to add on a kind of softer, less extreme note is in response to Catherine, which is ill people are expected to perform their illness, and they're oftentimes not allowed to have fun or seemingly or to laugh or to experience pleasure because it seems to not be in line with the narrative of them constantly trying to get better or to deal with their illness. But we are complex, nuanced beings, and one of the best things we can do is laugh and soften. And what I'm always trying to bring to people's lives who are dealing with serious illness, knowing that it's the most important thing for me, is distraction. Like really hilarious, joyful, pleasurable distraction. Like what can I bring you that will make you laugh? What can we do that just has no purpose? How can we step to the side of this situation? Yeah.
Yeah, Alicia.
I'm just reminded when Sophie, you spoke about this notion of forced presentism. It reminded me of something you said in your talk a few weeks ago about how for many people who have suffered serious illness or violence in their lives, that the pandemic did not come as that much of a shock. There was the thing that most stood out for me in what you said, because I remember at the very beginning, you know, when the roads went silent and people were caring for each other and looking after their health in a different way. I remember writing an email to a friend saying almost exactly that, like it feels like the world is catching up with the way we've been living all our lives, taking care of the planet, noticing the difference in, you know, what's going on ecologically, noticing our health, you know, all of this stuff. And so I had this wider question, particularly for you, Sophie, but anybody else who wants to come in on it, which is like about narrative and like the notion of like the rhetorical triangle, you know, like pathos, ethos, logos, but then this other idea of kairos, like just because we're talking about time, the notion of borrowed time and the difference between like chronos and kairos, like I'm hearing a lot of people speak in COP26 about like the time is now. And I'm slightly like allergic to that in the way that they're speaking of it in like, if it's now, then it's kind of too late already. But then there's something about the presentism of like the notion of kairos that is such a resource for us now. So I don't know, I just wondered if Sophie had anything to reflect on that.
I very much agree with both. Yeah, when the pandemic happened, first of all, I had been the dinner guest for forever who had said it's going to be a pandemic, give it 2 years. So it happened, and I was kind of like, oh, look. But for chronic illness, yeah, people were finally washing their hands and wearing masks. With someone with an allergic condition, I've been wearing a mask forever. I was like, oh, okay. Now everybody's doing that. But in terms of time, I do think that you're never timely. If you're on time, you're already late. You're always untimely. And that's something I always think about with illness is it's, you know, you never feel like the flare's on time. You never feel like you have enough time. And that, in fact, to be prepared and to be present means to be untimely, to be constantly stepping outside of the linear arrow of time and realizing that you're in this borrowed time. And I do think that if we're going to have conversations about our climatological condition, it's going to have to happen in a different kind of temporal epistemology. We're going to have to queer our ideas of how we use time, how we sit inside of it. And I also think that time is relational. Time is time spent with. It's an ongoingness alongside something else. It's an attention and care to something else. And I do think that if the pandemic has given us anything, it is that we must be in relationship to other people moment by moment for our needs as supply chains shut down in the US, for medicines we can't get, that time is a passenger experience.
Thank you for that, Sophie. We've got a few minutes left, and so I wanted to invite everybody here on the screen, but everybody else out there who's listening as well, to give you some time to say something on stage that has occurred to you at any point, either during this session or during the last couple of days. If there's anything you would like to say, not necessarily as a way of summing up, but just that you feel like needs to be put into the conversation. And there's a deafening silence. So I do want to pick up on one of the things Catherine said, which is about carers, who I think often are damaged psychologically almost as much as the patient with these kinds of lifelong ongoing problems. I think if we have a lifelong carer, the impact on them
And also those who, again, like we talked about with disability, don't fit the parameters of being classed as a carer.
No, that's right. They're not officially carers, just as we may not officially be disabled. But yes, there's, that bureaucratic line makes it very hard to. I think, in my experience, the person who cares for me doesn't think of herself. She doesn't label herself that way, but actually, the psychological impact has been enormous.
Mm. I don't think of that way with regard to my daughter. I'm her mother. Why would I be anything different whether she's experienced illness or not? It's a different thing. I mean, actually, and maybe I'm kind of there's something that keeps kind of cropping up for me as we've all been talking, and there was something that I experienced. So maybe.
Oh, it's a shame we've lost Catherine for a moment. I'm sure she'll come back, but Matt has put a comment in the chat that Catherine, we've lost you for a minute. I hope you can hear me, and I hope you reappear in a moment. But Matt says he's loving this conversation. He enjoys being a listener without much of the urgency to add, other than vicarious comments on my partner's chronic condition mentioned above. I'm looking forward to sharing this with her. Also, the book that Sophie, at least 2 people have leapt into the chat with a link to the book that Sophie shared. So we've got that information, which is great. Oh, you're back. Yes. I'm not quite sure where we lost you in your thread, but
and it's a slight tangent, but
we've lost Catherine again. We all have to learn to be terribly still when we're in these kind of streams, because too much movement knocks out the signal. Anyway, we are just about done with time anyway. I see the clock's just ticked into 1300. So I want to say a huge thank you to everyone who's come along, to everyone who's participated. Obviously, I'd like to thank Catherine and Alicia and Sophie in particular as our guests in this session. I think it's gone into some really interesting places, probably places I never expected to go. Apologies for the graphic conversations about my insights. But I just want to thank you, and I hope that this conversation can continue in some form. But thank you very much for taking part. Okay, well, bye-bye.
Thank you, Richard. Thank you, Lisa.
Thank you, Sophie. Thank you. Bye.